Hi everyone. In this presentation, I will discuss a new modality which has been introduced recently in neonatal care as a modality of point of care assessment of lung parenchyma. So this presentation is about basics of neonatal lung ultrasound, and it is just a brief introduction to this new modality. My objectives: to discuss general physics of ultrasound, assessment of lung ultrasound, the technique of lung ultrasound, lung ultrasound severity score, lung ultrasound as a diagnostic modality in neonatal lung diseases, including RDS, TTN, chronic lung disease, pneumothorax, and pneumonia. But why ultrasound? It is real-time, portable, no ionizing radiation compared to X-ray, inexpensive or relatively inexpensive, dynamic. So good for functional assessment. You can assess the difference between inspiration and expiration in sick infants, and you can get an impression about lung collapse and end of expiration, for example. So this dynamic study, it can be recorded as video clips, and you can assess the lung expansion in relation to different phases of respiration. It also can guide procedures like tapping of pneumothorax or pleural effusion, for example. General physics of ultrasound. Ultrasound is basically conversion of electricity, high rate interrupted electrical current, to ultrasound, and ultrasound in very high interrupted current rate, typically between 1 million interrupted current or ultrasound waves up to 20 million. In neonates, we are using usually high frequency. So the higher the frequency, the shorter the wavelength. Ultrasound composed of waves, and the shorter the wavelength, the higher the frequency, and better penetration of superficial structure, or better high resolution and good assessment of superficial structure, compared to low frequency with longer wavelength, which is needed more in adults or to evaluate deeper structure on expense of resolution. So the low frequency can penetrate deeper but on expense of resolution. High frequency can give you good resolution, and also it is good for superficial structures. So in neonates, we are relying more on high frequency ultrasound probes. And transducers, we have three main types of transducer, and any one of them can be used in lung ultrasound. Linear array can penetrate superficial structure because most of the linear array probes are with high frequency, and also can give you a good surface area of assessment. Curvilinear array can also be used in lung ultrasound. Phased array, which is typically used more in echocardiography, it also can be used in lung ultrasound, but still the best transducer for lung ultrasound assessment is linear array probe. We have four main types of media in our body. Air, which is basically occupying healthy lung, and it's the aim of ultrasound. Ultrasound cannot penetrate air and just will be reflected at the surface of interface between pleura, which is a thin film of fluid, and air, and anything like below the pleura will be just appear as artifact, and we call that airline artifact, and we'll discuss that in more details later. Or fluid. Fluid is level of ultrasound, and fluid can let ultrasound pass easily through it. Soft tissues, and more soft tissues also allow ultrasound to pass easily, and harder tissues will not be allowing ultrasound to pass as easier as soft tissues. And more soft tissues containing more blood, the same like muscles, and harder tissues containing less blood, like pleura, peritoneum, and pericardium. Bone. Ultrasound cannot penetrate bone, but the surface of the bone will appear like a crescent, and anything below the bone will be just a shadow. Assessment of lung ultrasound. So as we mentioned before, we are relying on artifacts, and we have two main types of artifacts: horizontal artifact or A-line artifact, or longitudinal artifact, which is B-line artifacts. And based on that, which one is more dominant, we can get an idea about the lung inflation or presence of fluid in the lung. So first, A-line artifacts, which is horizontal artifact. And the horizontal artifacts will be just a repetition of the interface between pleura and air. So the first line is the pleura, and the second one is just a mirror image of the pleura, or repetition. And this is reflecting air under the pleura, which could be either well-inflated lung or pneumothorax. The second artifact is a B-line artifacts, or vertical artifacts. This is reflecting interstitial fluid, and the most common example in our neonatal population is transient tachypnea of the newborn, TTN. And then when the B lines start to be coalescent or cannot be differentiated, then we call that coalescent B lines or alveolar fluid. So if we have the fluid basically in the alveoli, not in the interstitial space, then it is more severe, significant lung fluid. And the typical example for that is severe RDS. And at the end, we may have air bronchogram when the lung inflation does not exist and there's almost a collapse. So then you can see just air in the bronchi on the fluid background or collapsed background, and this condition we call it air bronchogram, and I will show some examples for that. So we have the collapsed alveoli, and in between you have some dots which is reflecting air bronchogram. So here in this example, that's actually example of normal lung. So we have the pleura, and the white echogenic line is reflecting the interface between pleura and air, and these black circles are the cartilage, which can allow penetration of ultrasound. And you have here air line and another A line, which is just a mirror image of pleura, and you have small longitudinal B lines artifacts, which is moving back and forth, reflecting sliding of the visceral against the brighter pleura. So that's a normal line. So B lines are really minimal compared to here. You can see the pleura, and you have longitudinal B lines reaching the bottom, which is considered as significant B lines. That's reflecting significant interstitial fluid. That's different from the image with the normal lung when you have just small B lines not reaching the bottom. You have A line very clear here, and there is no A line in this image, basically just B line. So you have the impression of a significant interstitial fluid. If you have two or more longitudinal B lines, that's enough to give impression that there is significant interstitial fluid, which is different from if we have the pleura and you have pleura not well demarcated as before. So the pleura does not appear like well demarcated echogenic line. It just diffuse with what's underneath the pleura as white out. So we have here alveolar edema. You cannot differentiate longitudinal B lines anymore, and everything is just echogenic or bright. So you have significant amount of fluids in the alveoli, not in the interstitia. So this infant is infant was RDS, significant RDS before giving surfactant. And then we mention about air bronchogram. When the pleura appears interrupted, not as continuous well demarcated line, and you have echogenic circles below the pleura, these circles reflecting air bronchogram, and this infant with lung collapse or severe RDS with lung collapse. This can be differentiated from another type of bronchogram. When you have bronchogram still like tiny echogenic dots, but on hypoechoic, and the hypoechoic lung here is almost the same like liver in the bottom image. So this infant was pneumonia, and they have the lung surrounded by pleural effusion. So that's significant pneumonia with pleural effusion, and I prefer to call that fluid bronchogram in comparison to air bronchogram with collapse. So that's side by side how to differentiate collapse from pneumonia. And the bottom image you have the liver, and you have minimal fluid above the diaphragm, which is pleural fluid, and you have the lung tissue here with fluid bronchogram. It's actually very difficult to differentiate the echogenicity of liver from lung. So that's what we call it sometimes hepatization of lung tissues, when the lung is really inflamed and rich in fluids. Then we'll discuss lung ultrasound technique in brief. In neonates, we can evaluate the lung in basically three zones in each side. So we have R1, which is reflecting right upper lung, R2 right lower lung, R3 lateral surface of the lung. The same for left side, L1 left upper lung, L2 left lower lung, and L3, which is lateral surface of the left lung. And if you are using a linear probe, the surface of the probe is enough to cover the entire upper lung, and sometimes exceeding that in very premature infants. So basically you are evaluating almost all of the entire surface area of the lung by just considering three zones in each side. And we can also add R4, which is assessment of costophrenic angle for any suspicion of pleural effusion. So R4 on the right side and L4 on the left side if you are interested to assess any possibility of pleural effusion. Lung ultrasound severity score, which has been published in adult as well as some neonatal literature. So we can consider three lung severities plus the normal lung. So the normal lung will be given score of 0, or pattern number 1. When you have well demarcated pleura, dominant A lines and just minimal B lines not reaching the bottom. So that's score of 0. And then when you have longitudinal B lines, more than 2 or more at least in one single image, give a score of 1. So this is representing interstitial fluid, and typically can be seen after birth in infants with TTN, or later on, for example, if you have preterm infants with PDA, and the PDA causing more interstitial fluid, it also can be seen in that condition. And then when you have coalescent B lines, you cannot differentiate, you cannot count B lines, as there is no A lines anymore, and more thickened pleura, less well demarcated, interrupted thickened pleura. So this white out lung will be given a score of 2. And then the maximum score, which is score of 3, can be given if you're able to see air bronchogram. As we mentioned before, the pleura is more thickened, more interrupted, and still white out lung, plus air bronchogram. Lung ultrasound as a diagnostic modality in neonatal lung diseases. The most common neonatal lung diseases are RDS, TTN, chronic lung disease, pneumothorax, and pneumonia. In TTN, one of the pathognomonic features of TTN in lung ultrasound, when you apply the probe, and the index mark of the probe should be directed upwards to the head, which is consistent with this landmark. So the upper lung will be more aerated, as you can see here, well demarcated pleura, and with clear A lines, compared to the caudal part of the lung with more alveolar fluid, less demarcated less demarcated pleura. So this, we call this as double lung point in TTN. That's pathognomonic, and it has been validated and published as a pathognomonic feature of TTN, which you cannot be appreciated in X-rays. In RDS is more homogeneous, either alveolar fluid all over the lung, or in severe cases you can appreciate some air bronchogram, interrupted thickened pleura with air bronchogram all over the lung. So that's a right lung and lower lung, upper and lower. So you cannot differentiate any difference between upper and lower zones on both sides. So that's more homogeneous distribution of alveolar or interstitial fluid. So the thickened pleura and air bronchogram, both sides. Diagnosis of pneumothorax. X-ray is still the widely used modality to diagnose pneumothorax, and this infant was right side up, was right pneumothorax, and you can see the collection of air above the lung and partially collapsed lung, and also you can see that in the ultrasound in the form of A-line artifacts. There is no lung slidings, you cannot see any B lines at all. So there is no lung sliding, silent lung, and you can confirm that if you move the probe and able to detect a double lung buoyant when you have the lung which is still partially inflated, and the pneumothorax, or sliding lung, sliding portion of the lung, and the collection of the pneumothorax. So that's actually area of air. Here collection of air, there is no lung, but here you have still some, can see some sliding. So that's a double lung point in pneumothorax. Again, you have double lung point, A lines, side by side with the partially collapsed lung with alveolar fluid. And you can confirm pneumothorax with applying M mode. When you apply M mode to pneumothorax, the A lines will appear as barcode sign, or the same like C. the waves of moving waves of sea at the beach. So this is the same patient with the pneumothorax after tabbing of the pneumothorax, and I started to see here some echogenic dots and less prominent barcode sign or A lines, and this after complete tabbing of the chest. Now you can identify, instead of just sea, you can identify the sky, sea, and sand. So it will appear like granular appearance of sand at the surface of the lung. So that's a lung after resolved pneumothorax post tapping of the chest by needle. So you have barcode sign, just repetition of A lines, and there is no movement. And here you can see sky, sea, and shore or sand. Or the same like if you are at the beach. Then diagnosis of pneumonia, and I think we have mentioned that before. In literature, lung ultrasound for diagnosis of pneumonia in children in meta-analysis. So I will read the conclusion of the meta-analysis. And it was current evidence supports lung ultrasound as an imaging alternative for the diagnosis of childhood pneumonia. Recommendations to train pediatricians on lung ultrasound for diagnosis of pneumonia may have important implication in different clinical settings. And also I can add with my experience, it is much easier to differentiate collapse from pneumonia by ultrasound compared to X-rays. For example, this infant, ex-preterm, 23-weeker, on high-frequency ventilation, and developed, like for sure you can see significant chronic lung changes. And then you have this area here, which could be collapse or pneumonia. It's really difficult to differentiate. By ultrasound, it was much easier to differentiate pneumonia, and it is the same area. In spite of change of ventilation did not improve, but 2 days after start of antibiotics, you can detect easy the difference compared to the first X-ray. Then the conclusion: lung ultrasound is easy, available at the bedside, safe and portable, international acceptance, and some units now all over the world they started to rely more on the ultrasound, lung ultrasound for assessment with less X-ray exposure. Reliable with or without X-ray, so you can do it as parallel modality to the X-ray or without X-ray. You can get more details about lung ultrasound as a new technique for diagnosis of neonatal respiratory diseases in this article, which will be available online soon. Thank you very much.